camera. Hello, colleagues. I'm going to give us just a few more seconds just to make sure everyone who's in the queue or in the lobby is let in. Okay, let's begin. Good morning, good afternoon, good evening, and welcome to today's panel discussion on applying behavioral science in health. My name is Benjamin Hickler, and I am the Behavioral Science Research Lead at UNICEF Innocenti's Global Office of Research and Foresight, and co-lead of UNICEF's Behavioral Insights Research and Design Laboratory, or BIRD Lab. I'm delighted to be the moderator for this session today, and I'm thrilled to see so many of you here. Today is day 5. This is the second to the last session of the 6th annual UN Behavioral Science Week, and I hope you've enjoyed as many of the sessions as I have this week. It's great to see so many colleagues who are curious or enthusiastic about the potential or possibility of applying evidence and methods from the behavioral sciences in our collective work. Our session today will provide a unique opportunity to peek behind the scenes a little bit and learn from some concrete examples from 3 of the leading agencies or organizations in the UN who are applying behavioral science to achieve results in health. The speakers today come from UNAIDS, UNICEF, and WHO. The session will begin with some opening remarks from Katrina Habersat from WHO's European Regional Office. Katrina has long been a champion of more innovative approaches to applying social and behavioral sciences to tailor health systems and service delivery to better meet the needs of communities. We will then have the benefit of hearing a series of short presentations from colleagues at UNICEF, WHO, and UNAIDS. The presentations will be limited in time. We're going to try to keep them short and sharp so that we have time at the end for discussion and a bit of Q&A. The colleagues who are presenting today are Rachana Sharma, who is the Chief of Social and Behavior Change at UNICEF's Ethiopia Country Office. Rachana will be talking about her work to set up the Ethiopia Bird Lab with Addis Ababa University and the Ministry of Health, and a particular project on maternal nutrition in Ethiopia. Our next panelist is Tina Licky from WHO Europe. Tina will be presenting about the tailoring health programs approach and will focus on a particular project on influenza vaccination uptake among health workers in Georgia. Finally, we will have a presentation from Eric Lamontagne from UNAIDS. Eric will be discussing a behavioral economics perspective related to HIV vulnerability and risky behaviors. So before I pass the floor to Katrina for these opening remarks, I just want to do a little bit of housekeeping. Above all, we do want this to feel a bit like a conversation and to have a really lively Q&A at the end of the overall hour. If you can, please use the Q&A button in the Zoom link rather than the chat or raising the hand. And we will try to keep track of the questions and prioritize the questions of most relevance when we get through the 3 presentations and to the discussion session. I will occasionally come in to remind you about the Q&A button. My hope is that in the end, we can create a real sense of dialogue and exchange. So now, without further ado, I want to pass the floor to Katrina Habersat for some opening remarks to set the scene for what is sure to be a lively discussion. Katrina, over to you.
Thank you so much. And if you stop sharing, I will share a few slides from my side. And I hope you're seeing the slide now with the woman
It
clapping.
looks good.
All
Yes.
right, terrific. All right, thanks so much for inviting me to say a few words for the opening. I always say behaviors are at the heart of health, not just what we eat and whether we exercise, but also how we engage with the health system, whether we follow a treatment plan, attend vaccination, whether a physician prescribes antibiotics or not, and how she interacts with her patients on any of the above topics. Behaviors are also at the heart of health equity because our living conditions, income, education, employment, level of inclusion in society, all of these factors shape our behaviors, which again have tremendous impacts on our health outcomes. Behavioral science and the related fields of research that we draw on bring together robust methods and evidence to respond to these challenges. They allow us to use more evidence-based, more people-centered approaches to supporting, enabling, promoting, sometimes even restricting behaviors. Behavioral science can be used by public health authorities to understand health behaviors, the context in which they take place, and how to address the barriers people are experiencing in taking up these behaviors, whether these barriers are individual or in the environment. Also, testing if interventions work is really central to behavioral science. So, as examples, these approaches have been used to increase vaccination uptake through addressing community-specific barriers and to increase equal access to care through intercultural mediation. And also, based on rigorous evaluation, we know that labels designed with the use of behavioral science can change our ways and habits for buying healthier food. This growing field of research and implementation globally and across many health areas have taken us quite far, and I think much further than any of us thought possible when we started working with behavioral science in health almost 20 years ago. I invite all of you here to join in. If you would like to advance the use of more evidence-based, more people-centered approaches to health behaviors in your setting, you can join one of the online or face-to-face trainings offered by the agencies who are here present today and presenting, or you can read some of the considerations or guidance documents that are available for setting up behavioral insights units or advancing the use of behavioral insights for health. Or you can simply engage in a conversation with your leadership to advocate for more resources, funding, so that you can include a dedicated behavioral insights component in your next project. I personally think that we're at a critical juncture in global health. I think there's a unique opportunity for change in how we understand and address behaviors in health by applying more people-centered, more evidence-based approaches. But this field is still widely underfunded and underprioritized. And the responsibility rests on public health authorities and all of us in the global and regional partner organizations, academic institutions, and of course the wider public health ecosystem to use the opportunities provided by behavioral science in health. This requires a collaborative effort, commitment to continuous learning and innovation, and also, I guess, a shared vision for a healthier future. And I'm really hopeful that we can get there together. And I think this session today is a really nice step in that direction. So thank you and welcome again also from me.
Thank you so much, Katrina. That was inspiring as always, and just does a really nice job of setting the scene for the conversations that are about to come. If I understand the order correctly, I think we are going to go next to Rachana Sharma from the Ethiopia Country Office, UNICEF. Let me hand over to you, and you should be able to share your slides.
Thank you, Ben. Can you confirm you can see my slides and if it is on play mode?
It is about to be, yes. Now it looks
Okay,
like it should. Thank you.
Good. So good afternoon, everybody from Ethiopia. Just like Katrina said, that behavior is at the heart of health. Behavior is also at the heart of nutrition programs and health and nutrition are so intrinsically linked. Setting the stage on what UNICEF has been doing to enhance behavioral science practices and research within the organization. Like my colleague Ben said earlier, the UNICEF Global Bird Lab, which is a partnership with the Global Office of Research and Foresight, and a network of SPC staff within UNICEF and outside implementers and partners and academic partners, has been thriving and enhancing behavioral science within the organization. A main objective of the lab is really to enhance behavioral science use in the Global South by building capacities across partners, especially academia and non-government partners. Currently, the Global Bird Lab supports over 30 projects in 25 countries. And you have a link to get the details. This is a visual depiction of those 30 projects, as you can see, right from the west to the east, with a lot of projects running in Africa. Very happy to report that drawing from the Global Bird Lab, the Ethiopia UNICEF office was able to secure a partnership with Addis Ababa University School of Public Health, to be specific, Behavioral Science Unit, to set up a country bird lab in this university. And the idea here again is to enhance more and more academicians, NGOs, government donors, understanding the importance of behavioral science and joining this movement, if I may say. With the Bird Lab, we have been running 5 projects, and in the process, we have been building the capacity of the Bird Lab Ethiopia on BI projects from end to end. Today, I'd like to talk about the project on maternal nutrition behavior adherence. In UNICEF, we follow the depths approach. Most of you know that we start with the definition of the problem at hand. We explore through research and diagnose the actual problem. This is led by working with the stakeholders, primary stakeholders and secondary both, to come up with behavioral solutions, which are tested, and based on the testing results, they are scaled up. So coming to the project that I'm going to speak about, the Maternal Nutrition Project, the context is that despite a lot of progress in the country, malnutrition and anemia contribute to still a lot of maternal and child death in the country. The technical solution between donors, UNICEF and government was to transition from the iron folic acid supplement to multiple micronutrient supplement. And this was expected to save the lives of thousands of children and also a million of daddies. The behavioral solution that we had to find out was around these 3 behaviors: compliance to MMS, uptake of ANC, and also diversified diet of the pregnant women. So what did we do? We started with the qualitative research, which was desk-based research, including 9 key interviews with government and UNICEF stakeholder. This led us to drawing out a social behavior change strategy. What we found in the research was that social acceptance, education, messenger effect, convenience, behavior of the health extension worker, support from husband and mother-in-law are some of the motivators for these behaviors. If these factors are available, the behaviors are practiced. If not, there are also multiple barriers which push the woman away from practicing these 3 behaviors, which are the risk perception, lack of trust, and the hassle factors and the friction also in terms of availing the health services at the health post, or even the behavior of the health workers. So we went ahead and did a co-design workshop with all the 3 categories: health professional, one of the, I would say, primary stakeholder, the pregnant woman, and the husband and the mother-in-law. We arrived at 10 behavioral prototypes, turned out to be a long list, co-designed with these stakeholders. However, with further stakeholder consultation and looking at which ones were of high fidelity and low effort, we zeroed in on 3 behavioral prototypes. So these are the 3 behavioral solutions that we are currently testing. There is a board game called My Journey to Motherhood, The behavioral outcome expected is that couple will together play it, and that their information, support, and decision-making on these three behaviors improves, and we are able to close the intent to action gap. The second one is called it's a graphic booklet called A Supermom's Journey. There's a video version as well. This is expected to again enhance the couple's knowledge. And the third one is targeted at the health worker called Empathy Training Module. And it's expected to enhance the health worker's caregiving ability to the pregnant woman and her family. So just a reminder that we are at the stage of testing these three behavioral solutions as per the steps. The testing is with a sample of 800, 200 pregnant women for the three prototype each, and 200 for the control group, which does not have exposure to these behavioral solutions. And the variables are the three behaviors I've mentioned earlier. We are expecting the scale-up result to be available in 2 to 3 months' time, and the scale-up decision with government to be taken, which would lead us to implement the solution selected or modified in 21 districts by September 2024. Before I end, I just want to acknowledge my colleague Hiva and Busara, who has been our partner in this journey, along with the Bird Lab Ethiopia. Thank you very much.
Excellent. Thank you so much, Rachana. Now, I would like to invite I see that people are putting some questions in the Q&A. Please, any attendees or participants, please continue to add your questions. Some are being answered by text, and some we will prioritize for the discussion at the end. Now I'd like to hand over to Dr. Tina Leakey from WHO Euro, and I believe you should be able to share your screen.
Yes, I am just attempting to. It worked so nicely before. All right, can you see the screen? Great, thank you. Thanks so much, Ben, and thank you, Rachana. Really lovely example you shared. So I work for the Behavioral and Cultural Insights Unit at WHO Regional Office for Europe. The unit was created in 2020, building, as you heard from Katrina, over almost 20 years of work applying behavioral science to vaccination. And our unit works across all 53 member states in the region. A lot of our work is directly with public health authorities in the countries to advance the use of more people-centered and evidence-based approaches to health behaviors. Here on the slide, you can just see some examples of ongoing work where we're providing technical support. And you can see that they really range across many different geographic areas and contexts, as well as health behaviors. And there was a question, I think, in the Q&A around, what areas of health does behavioral science apply to the best? And I think this just exemplifies that it really does apply across the board. And then it's a matter also of national health priorities, where to start. And most of these projects were guided or are guided by an approach that the Behavioral and Cultural Insights Unit here at Euro developed over the years. It's called the Tailoring Health Programs Approach, or THP. And the guide is it's available online alongside a very useful toolbook. And this approach uses an adapted version of the capability, opportunity, and motivation model of behavior change that was developed by Professor Susan Mickey and her colleagues. And it's a guiding framework that we find is both holistic and accessible, even for non-experts to use. So the entire THP, or Tailoring Health Programs approach, consists of 4 phases, and it uses a theory of change to guide decisions throughout an end-to-end BeSci project. The first 2 phases relate to using data to define target groups, and secondly, conducting research to understand barriers and drivers to behavior. And I'll give a concrete example, as Ben mentioned, from a project we're currently undertaking to understand and address low flu vaccine uptake among health workers in Georgia. And in this example, the situation analysis in phase 1 consisted of a synthesis of available data, looking at vaccination coverage, infection rates, mortality, looking at how flu vaccination is currently organized in Georgia, any past research on barriers and drivers, as well as a review of international evidence. And this allowed us to define the target group, which is health workers, and also to determine what kind of further research into the barriers and drivers might be needed. And as a result, we chose to do some rapid key informant interviews with health workers to understand how the flu vaccination was delivered to health workers and what their experiences, knowledge, attitudes, and so forth were. And here are just some quick examples based on or organized by the COMBI model that we gained from those very quick, short half-hour interviews. First of all, on capability, we found that a lot of health workers thought it was voluntary, not mandatory, which is actually not correct based on Georgian legislation to get the flu vaccine. There were misconceptions around things like the contraindications. Should I get the flu vaccine if I've got a runny nose or I'm feeling a bit under the weather? Motivation-wise, most people actually said they wanted to get the flu vaccine, but they cited things like procrastination or lack of prioritization as barriers. Overall, it was considered easy to vaccinate, but then when we sort of looked into it, it turned out that often hospitals would only have one place where physically this could be done, and there was no weekend or evening slots. And on sociocultural opportunity, there were very mixed findings in terms of how supportive health workers found their leadership and management in terms of getting vaccinated. And we were asked to reflect in this session on some challenges and opportunities. So in terms of those first initial 2 phases of conducting a behavioral science project, some of the challenges we're finding are that end-to-end projects are resource intensive. So it's really important to invest time in selecting the right behavioral problem and ensuring stakeholder buy-in early on so it doesn't sort of wane off as things get tough. Secondly, the importance of behavioral diagnosis to ensure that the interventions are addressing the right barriers. And here, as I mentioned, we use COMBI and we invest some time to ensure that the stakeholders really understand this holistic model of behavior change. Another challenge is that stakeholder interest may wane if the formative research, the sort of barriers and drivers, takes too long. So that's why we're trying to do increasingly very rapid qualitative research and also use more iterative ways of working, as I'll show next. So the third phase is all about designing the intervention, based always both on a review of the scientific evidence and co-creation and co-design with stakeholders and end users. As an example, here is what we designed together with the hospitals in Georgia over several co-design sessions. It's a multi-component intervention, which consists of a declination form. That's a mandatory written statement that health workers sign if they do not wish to get vaccinated. And this, in behavioral terms, creates a decision point where, which addresses this tendency we found to procrastinate, to not get vaccinated. The second component is about increasing access through things like mobile vaccination carts that go around the hospital. Vaccine reminder card helps address the barrier of the people who, in the moment of being offered the vaccine, maybe aren't feeling 100%. They prefer to delay. So the card allows them to write when and where they wish to get vaccinated or when and where they plan to get vaccinated. Vaccine champions address this mixed leadership support. Information provision allows us to overcome some of the misconceptions around flu vaccination. SMS reminders address forgetfulness. And lastly, we also introduce vaccination targets at the healthcare facility level, which currently don't exist. So the final stage then, what is left is to implement and evaluate. In the case example of Georgia, we're doing a feasibility study in the coming flu season to look at 4 things essentially. Is the intervention, all the 6 components, is it feasible? Is it feasible in a future year to assess its impact? What is needed? Do we have it? What would be the scalability of this? Can this be scaled across all hospitals across the country? And also look at some exploratory impact assessment. So we will roll it out in 2 intervention hospitals compared to 2 comparison hospitals with a number of data sources, both quantitative and qualitative. So just my last slide then, in terms of challenges and opportunities related to phases 3 and 4. Firstly, it's important to have a clear path from all this in-depth, rich behavioral diagnosis about barriers, a clear path from those to what the interventions are. So we avoid the situation where there's often a tendency to go with a campaign or a training intervention. And tailoring health programs, we use the behavior change wheel to create this link. We need to ensure that interventions are based on robust evidence and evaluated scientifically. This is where academic collaborations are essential. Thirdly, we need to understand not only if the intervention worked, but why or why not, and for whom. And this is so we can avoid a situation where we have a null result, we've invested a lot, and we have no idea why it didn't work. So here the solution can be to collect data on the implementation process and outcomes, as well as on mediators and moderators like beliefs and attitudes. And finally, often, even if you get a great result, scaling can be difficult. And this is why we try and increasingly assess the feasibility of the scaling as part of the evaluation, as well as engage with a broader set of stakeholders early on and consider sustainability. Over from my side, I hope that was useful. Thanks.
Ben, you're muted.
Ben, I'm not sure we hear you.
No, we can't hear you, Ben.
You're muted, Ben.
It doesn't show you're muted. Maybe you're, oh, now you are.
I see his mic shows muted.
Okay, maybe I can, maybe
I will, okay, so
Eric will just start. Yeah.
Thank you. Okay, so Ben would have say, okay, I want to introduce you to Eric. So this is me. I would like to thank you, Ben. Big thanks to all the participants for your interest in behavioral science and in health. And thanks also for this great opportunity to give you a really brief introduction to behavioral economics and how it applies to HIV. So we're going to use the HIV case here. There's a lot of material, okay? So I won't be reading the slides. Don't hesitate, take screenshot, ask questions at the end or now, and you can even ask for the presentation. So next slide, please. So except for a minority of economists, economics is not about money. It's about choice or lack of choice for some population group. It's about how people make and take decisions. You already know for the great presentation we just had what behavioral science is. So what is behavioral economics? Well, behavioral economics is about working hand in hand with health, psychology, sociology, anthropology, and many other areas to bring knowledge and evidence about what motivates people to take action that could promote their well-being. Said differently, behavioral economics is about better understanding how diverse and complex are people's decision-making processes. Next slide, please. There are several behavioral economics principles you already know, and you heard them now. Risk aversion, for example, is the tendency to prefer certainty over uncertainty and to avoid risk when given the option. Present bias reflects the fact that people tend to disproportionately focus on issues that are before them in the present moment, paying less attention to future payoffs and consequences. Tina just mentioned the procrastination, and it speaks about this. Not just about the possibility of modifying or shifting people's behavior without explicitly regulating it and without imposing significant rewards or punishment. Finally, I'd like to mention social norms, which are the unwritten rules about how to behave in a society. This can lead to stigma and discrimination, compounding the effect of the other variables I just mentioned. Next slide, please. So UNAIDS, with many civil society organizations, ran a huge global happiness survey among 115,000 sexual and gender diverse people in almost 200 countries. We took a subsample here that you can see on this slide. And what we found when we were comparing some behavioral economics variable for HIV status, it appeared that, as you can see it clearly from the table in the slide, how HIV negative people have lower willingness to take risk, lower preference for the present, so they don't procrastinate as much, and they have a higher life satisfaction. They take, and you can see the down oriented arrows in terms of HIV risky behaviors. At the other end of the spectrum, we found that people living with HIV were also people with high willingness to take risk, high preference for the present time, and more or less equal life satisfaction. They were also more likely to engage in risky sexual behavior in terms of number of unprotected anal intercourse partners, transactional sex, whether paying for sex or being paid for sex, and sharing injecting drug equipment. Next slide. So these findings, what are they for? Well, they can help in designing and implementing more people-centered HIV program. And you can apply this for all health program. For example, here, scaling up the use of pre-exposure prophylaxis, PrEP, as we call it. That's really effective for those with low risk aversion, reducing the risk of HIV infection among risk lovers, as we call them. Moreover, offering long-acting PrEP instead of daily PrEP can align better with the needs of individuals with high time preference by decreasing the frequency of adherence actions. Offering incentive for regular HIV testing appeals to both those with high time preference and the risk lovers by providing immediate rewards for health promoting behaviors. Next slide, please. I'm not going to read all this. You will see it. I would like to insist on a take-home message here is that, well, behavioral economics is not an alien separate from the rest. You could hear in this presentation how it works with all the other aspects of human nature, particularly here as we link it to health behavior. Okay, so behavioral economics just provides evidence and knowledge for tailored, people-centered, and cost-effective strategies that can reduce HIV risk behaviors, increase HIV testing, and treatment adherence. So voilà, thank you very much for your patience.
And if someone can take, oh, he stops.
Is
Eric?
Ben there? Oh, great.
Okay, I
Yes.
switched the input. I guess my headset is not working. Apologies for the trouble. I'm also not able to start my video. Okay, now I can. Thank you, Eric, and also thank you, Tina. Those were excellent presentations. We have, I think, about 20 minutes for Q&A. And so at this point, I would love if all of the panelists, all the presenters could go on camera, and we can start to address some of the questions from the audience. There are a ton of great questions. Many of them are sort of big questions that I have a lot of opinions about, and I'm sure you do as well. So I think it's going to be a challenge to cover everything in the amount of time that we have. I guess my hope, I'm going to try to focus on questions that everyone might have a chance to weigh in on that are less specific to particular agencies or projects. And I just encourage you to jump in and build on one another's answers, but also try to keep it a little bit succinct so that we can get through a few of these. I think there was a question about frameworks and the role of frameworks. One, it's been answered in the chat. I do think it is a kind of important principle. So I would invite maybe, I mean, Tina and Rachana in particular, you both invoked frameworks to some extent in terms of how you approached the analysis and the diagnosis part of the process. Do you have anything to add about particular frameworks or the importance of frameworks?
I'm happy to go first, Ben. But I mean, I think it's fairly clear in our approach that the frameworks really are at the heart of it. And that's partly so that it allows us our thinking to be evidence-based from the start rather than driven by our assumptions about what drives behavior. So that would probably be the single biggest added value. And I guess the other point is, as Kurt Lewin said already in the 50s, there's nothing as practical as a good theory. And I think it is actually a very concrete, practical tool that also enables the dialogue with the stakeholders, because we're then talking with the same terms.
Yeah, absolutely. May I, Ben? Yeah, very well said, Tina. I don't think I have much to add there, but for sure, the frameworks really give us like a hook around which the research is designed, and then the analysis happens, and then the prototyping or the designing phase also begins. I just want to add that it's very important to choose the right framework, because depending on which sector and what behaviors you're targeting at, and who's really the primary stakeholder there, the choice of framework, if wrongly done, may really affect your results, but if carefully done, may really lead you to, gold mines and very good behavioral solutions. Thank you. Mute, Ben. Can't hear you, Ben.
Yeah,
you're back.
Error message coming up from my, I don't know what it is, but if I go out, Mary, can you come in and
yes, I can do that, no problem.
Help out? It might happen again. I don't know why, but I can see this little exclamation point by the microphone. Okay, thank you both. I was inviting Eric if you felt like you wanted to weigh in. Otherwise, I'm trying to think of a creative way, because we have like 8 excellent questions, of a creative way to combine a couple of them. A few of them are sort of meta questions about some of the things I think, Tina, that you touched on in your reflections around ownership and buy-in and getting traction with the right stakeholders and keeping the momentum. I think that this stuff, just having worked for a number of years in this space, is really important. And it's not really the technical things, it's the hard work that goes around it to get results and make things happen. I would love to invite you all to reflect a little bit on this bigger issue around getting the work done. And Rachana, maybe can I invite you to go first?
So I really think that there are a lot of elements when we make presentations like this, which does not come out. And when we really want to run a behavioral science project from end to end, there is a pre-part, which is the green room part, and then there is on the stage, and then there is behind the stage also, even after the project has been running on the stage. I think internal pitch, internal advocacy, both within the organization, we all are situated, various UN organizations, then with the ministries, government that we work with, then with the institution bureaus and the donors and the funders. So I think that is a big leg of work that one has to do, because the fine line of difference between a project which draws from behavioral science, various models and the steps, and a project which jumps into solutions which are based on anecdotal evidence. The investment and the loss is something that is often not talked about. And hence, and people are in hurry. So everything needs to be done like yesterday. So those are some things, important things, consideration in terms of getting it done from end to end. Thanks.
Thank you. Tina, yeah, there actually was a question directed to you that's precisely about this, about stakeholder buy-in from the beginning. So I was hoping you could also speak to this.
I'll be very brief. Yeah, I think Eric has a comment as well. So I think the question was, how do you know they're sufficiently bought in? And I think a strategy that we often use is to start small and maybe do a smaller behavioral science project first to really see how far can we get this buy-in. So the Georgia fairly large scale study I presented followed a much shorter, briefer online RCT, online experiment that we did on encouraging cervical cancer screening. And we found that was a sort of end-to-end 4-month project. And we saw it went very smoothly, and we could get a sense of how supportive the different partners were. So then we could build on that in the bigger project. The other very practical tip is this sounds a bit like we're testing stakeholders, which of course we're not really doing, but it's just to have a project collaboration agreement or a memorandum of understanding or something, and see, can they get that through internally? Because if they can't even get that through, then it's probably going to be difficult longer term. Over.
Thanks, Eric. Yeah, I would invite you to build on this if you can.
Absolutely. In fact, yes.
Oh, now you've gotten on mute, Anak.
Yeah, I have at least 3 amazing questions on the Q&A. So, and I want to make sure that for now that I hold the mic, I'm not gonna lose them. So let me focus on these one first. Two anonymous attendees said, Eric, behavioral science, people are applying this more generally. Why behavioral economics, and why is it needed? And is it more appropriate for complex health issues? The short answer is no. Okay, behavioral economics is not an end by itself, and this is really important. And I know really well that by mentioning the word economics in behavioral economics, kind of scare people. Uh, Again, it is not about money. It's not about finance. When we say economics, it's just our tool in terms of econometrics instead of statistics. And we have instrument to measure fear, to measure altruism, to measure risk loving or not, and life satisfaction, self-esteem. These are variables that for, I'm sure all of you, doesn't sound like, is Eric really speaking about economics? Yes, we do. And we have something quite sexy, in fact, is that we also learn and how to look at the interaction between these different measures. So we don't provide you with a unidimensional analysis, but we do look at it from different angles. And this is why behavioral economics alone cannot answer and address these issues alone. We need the other specialists, and you have a nice panel of those specialists. Now, for HIV/AIDS, how is it used? I'm trying to do fast to make sure that I don't speak too long. Behavioral economics is gaining traction for about 20 years, which seems long maybe for some of us, but it's pretty short in the history of HIV, for example, which is 40 years. And even longer for other health issues. So it's quite recent, and it is gaining traction also within our organizations. Okay, but the type of just take this thing home is that people, even in our own organizations and our neighbors, are asking us the same question that you're asking, which are really relevant. And once we start working together, things it's not like 1 + 1 = 2, it's 1 + 1 = 3. And this is the beauty of it. But just be careful if you hear a behavioral economist working alone. Is probably maybe missing part of the big picture. I have another colleague here, Fern, who's also a behavioral economist, and she's working with me. Maybe she wants to chip in, because I focused on 2 questions, but there are others. Ben, if you don't mind, just if she feel like it, can she just chip in? And
yes, please. No, I was going to invite Fern to weigh in.
Thank you very much. And I don't want to think the key thing is that over the past, an economist perspective, early on, they thought, bring in economists to do cost analyses, and we need to find a biomedical solution to this epidemic. As time went on, there was more and more recognition of the importance of adherence, linkage to care, how you provide services, but also early on in the development of biomedical research, where you're designing things and you need to take into account the user preferences in their reality. So I just wanted to say that in the early decades, 2000, there was very little recognition, but now if you go to some of the big donor meetings, it's all about user preferences, incorporating their perspectives, because we've learned the hard way, and we've spent millions and millions of dollars on biomedical interventions without incorporating how people can use them in their daily lives. And now they've come to recognize. So that's what I wanted to add, is I do think that there is an increasing recognition, and we have a great role to contribute, tweaking around the edges. Sometimes very small interventions can make your whole trial a difference between your trial, whether or not you put the bench for men coming for male circumcision behind, separated from young men. It might mean that you won't get any adult men coming if you don't do some of these small things. And some of the behavioral research before can be very cheap addition to your big trials and interventions. Over and out. Over to you, Ben.
Thanks, Fern. Yeah, no, it's a really important observation. And, sometimes I hope that we're finally at a point where we don't need things to go terribly wrong for people to take seriously the importance of understanding humans and their humanness and behavior. Putting people kind of at the center of the way we approach these things. It does feel like progress. It feels like there's momentum in the field. And yeah, hopefully we can build on that. There's at least 3 more questions that I think that we can cover before the end of our Q&A. One of the most I want to be a bit democratic, and I see that there is kind of an upvoting system. And one of the questions that seems to resonate for people in the audience is this question about the role of qualitative research. The question is that it's clear that qualitative research is critical to designing high quality behavioral science interventions, but sometimes qualitative methods are viewed as being not rigorous enough. And I do think in some circles, behavioral science is really conflated with measurement and quantitative approaches. I think we could also link this question to the question about co-creation, perhaps, and the role of co-creation in some of these processes, since that came up in a couple of the presentations. So if I can go to the panelists, and I'll try to do it and let whoever feels most compelled to speak first.
I'll go ahead with this.
Great.
as a quantitative researcher, working on a lot on discrete choice experience, which is a very quantitative method, it's total question of garbage in, garbage out. You can do the best quantitative methods, but if it doesn't acknowledge and address the key questions that are driving people's behavior, you're not going to get anything. And it's the same with trials. It's the same with quantitative surveys. If they're not presented in ways that people want, if they don't have the right questions on there. So it absolutely needs to go hand in hand, and bringing communities in your target group, right, which is not supposed to be a target group, it's us, you can't do it without. So I think as a quantitative researcher, I would say nothing without qualitative methods. You can't get anywhere. Thank you for the question.
I can comment maybe briefly on the qualitative, and then
But I do think in
talk about the
qualitative
co-design
methods.
aspect.
Yeah, good, go ahead.
Thanks, Tina.
Yeah, so I think I definitely come across this perception that it's sort of soft and it's not rigorous and robust if you're doing qualitative work. And I think partly it's just, I hope, a matter of time, that as we do this more and we build the skills and the capabilities in a lot of places where this is not the tradition, that people will, through doing it, they will start seeing the value. But of course, yeah, I think in a lot of cases, we're still a long way away. And I think sometimes the sort of Trojan horse is to say we'll do mixed methods, so we'll still get the quantitative, but we'll use the qualitative. And then once people see the triangulation and how these things come together, I think that's often compelling enough. Thanks.
Absolutely. I think the same, Ben. I think why of the behaviors is so important. And in a previous panel, I remember Cash mentioned that what and why are equally important, and the story goes together. So what is happening and why it is happening, unless we have answers to both, we won't be able to design right solutions. But also, I think it's how you tell the story, because oftentimes we say that we are disseminating this research, but we don't say we are communicating this research. So how you tell the story around the findings of that research is equally important in terms of laying the emphasis on a qualitative research.
Thanks, Rashna. Can I stay with you just to try to also get your input on this question about co-design as a part of the process, because it came out across in your presentation, and the question is, what solutions did you come up with through this process of co-design that maybe you wouldn't have otherwise? What did it add?
Yes. Thank you, Ben. I did answer as well. I think if we did not do the co-design, we were in any case going ahead with a classical flip book, a communication tool, which existed from a couple of years ago on what maternal nutrition is, what are those behaviors to be adhered, and relying completely on the health worker to have the knowledge, the skills, and have the time to use that communication tool effectively to make the change and move the needle with the pregnant women. That would have happened if we did not do the co-design. When we did the co-design, we realized how important the role of the husband in understanding why she should take these pills, why her diet should be diverse, and why she should be taken 8 times for her ANC service checkup. All of this emerged, and role of the mother-in-law emerged, and then we came up with the booklet, the video, and the board game. And most importantly, her push factor to avail the services and practice the behavior was the root behavior or very neutral behavior from the health worker. So she said that if I don't experience connection, I don't want to go back. If I'm just treated as an instrument, I don't want to go back. And that's how the empathy training module emerged from the stakeholders workshop. Over. Thanks.
We have 2 minutes left, and I'm tempted to ask probably the hardest question. I think it was one of the first questions too, and it's not an uncommon question. And it's not an easy one to answer quickly, and it's one that I have a lot of thoughts about, but it's this idea about, what's new about applied behavioral science and what makes this different from what we might just call social and behavior change, or some of these other names for a discipline that's often focused on a similar thing, like applying evidence about human behavior to change what people do or to get certain kinds of program outcomes. I have a lot of thoughts about this. I don't know if we could do like a lightning round or have all 3 or 4 of you just come in and provide your 2 cents about whether this is old wine in a new bottle or whether there's something distinct about what we're trying to do here. Can I put you on the spot, Tina, to start?
Sure, I'll just say that I don't think the science is new, but I think the fact that we're more systematically starting to apply it to real life policy and service design problems is new.
Fern or Eric? If you want to
I stopped last time, so now I'm giving I'm letting Fern start, and I'll say a word after.
You passed the hard questions on, huh? Good one. Your time, actually. I think we have been working. I mean, some of us have been working on this for 30 years, nearly. But I think the recognition is new, and as Tina said nicely, it's just that we are able to now speak our voices and be involved in throughout the process is new, and I think that's just been a long process of slow uptake and behavior change on the policy side, but we're getting there. I'm gonna close up. I think we're at time. It's over to you, Ben.
Thank you. Yes, we are at time, and I want to respect that we should try to end on time because I think a lot of people were going to have to drop off at the hour. Thank you all. Thanks to the panelists for your wonderful contributions. Thanks to the organizers, UN Innovation Network, Johanna and Mary. Thank you all to the attendees, everyone who joined for the session. It was a lot of fun, and we hope to see you at the next one, I think in 1 hour, and that will be the last session for the week.